Hi, my name is Pooja Khatri. Today I'm presenting the Prisms trial, and this is a trial studying a population of patients with the mildest strokes. We defined this population by an NIH stroke scale score of 0 to 5, in other words, the lowest severity on the NIH stroke scale score, and specifically the subset with not clearly disabling deficits. We tested alteplase for its benefit in this population, and the reason we sought to do this trial was that these patients were enrolled in very few numbers in the major randomized controlled trials that have established alteplase for the treatment of stroke. We designed the trial as a randomized, active control, double-blind trial of specifically alteplase on the one hand, and then aspirin on the other hand as the control, active control. So it was designed as a 948 patient trial, and we enrolled 313 before, unfortunately, funding was halted due to being behind target recruitment. So we ended up underpowered, but we still learned a few things from the patient population. This was actually the first trial to test alteplase uniquely dedicated to this patient population, which represents a substantial portion of strokes out there. So we showed a numerically, to our surprise, a numerically lower rate of good outcome in the alteplase arm compared to the control arm. And actually, even when we looked at pre-specified secondary outcomes and exploratory outcomes, they were nearly all in the wrong direction, at least for our hypothesis. So they were all non-significant though, but certainly as physicians, we have to make yes or no decisions, and it leans you towards no. And then also we saw a higher rate of symptomatic hemorrhage associated with alteplase. Specifically, we had 5 bleeds among those 313 patients, and they were all in the alteplase group. We did a post-hoc calculation to consider how to think about this clinically in terms of the types of numbers we saw, and we were able to calculate that the likelihood that alteplase is beneficial in this patient population is 23%, and then the likelihood of seeing a greater than 6% effect size is 1.9%. So we also found, I should note, that this patient population did a lot better than we expected. Not perfectly, so still, an issue to solve, but about 80% of them in the overall cohort actually had no disability. So we were planning on about 70%. So in conclusion, this trial is clearly underpowered, and therefore we can't make definitive conclusions, but what I can say is that at this point, based on the only study dedicated to this population, the likelihood that alteplase's benefit extends to those with non-disabling deficits is low. And I do want to make sure that the take-home message is clear that this trial did not study patients with NIH stroke scale scores 0 to 5 and disabling deficits. For them, the role of alteplase is established as beneficial.